Okay, as Dr. Toth discussed, I'm going to do image-guided biopsies, a clinical review. What I want to go over are the options for tissue diagnosis of non-palpable breast lesions. And I will do this by reviewing the most common image-guided procedures by modality. There's many ways to approach this. I decided to go through by modality, so we'll look at ultrasound-guided biopsies, mammography-guided biopsies, and then MR-guided biopsies. And this is a very extensive topic. I wanted to hit a lot of the important points. So I hit a lot of these when discussing ultrasound, and in all likelihood, I may not be able to get through all of this, but it is all on the CD that you should have already. So in general, with each modality, I will cover core biopsies in each modality, fine needle aspiration with ultrasound-guided technique, and preoperative needle localization in each category. And then for each modality and technique, I want to discuss the indications and advantages, when to use each one, what their major contraindications and disadvantages are, the risks and informed consent that I go over with the patient, and then the basics of performing the procedure, and then follow-up, which is very important. So I'm going to dive right in because there's a lot to cover. I'll start with ultrasound-guided techniques. The major advantages with ultrasound-guided techniques are that there's no compression needed on the breast. There is no ionizing radiation used. Usually the patient is more comfortable because they are supine. We have here our ultrasound machine. The patient is usually on this examination table supine. And in general, this type of technique we've found to be faster and easier than techniques with mammography and MRI, although there is some difference with what you have available at your institution and what you're comfortable with. But in general, if I see a lesion under ultrasound, I usually try to biopsy it by ultrasound because of these reasons. The disadvantages with ultrasound-guided biopsies are that calcifications are often not well visualized or sampled. So usually, often never I use ultrasound for calcifications. Mammography is better for that type of lesion. Also, there is a pneumothorax risk with ultrasound that is not present with mammography-guided techniques. So these are the major. This is the consent that I go over with the patient and the risks, and this is true for ultrasound-guided biopsies, but really all biopsies. Anything that's additional for each category I can add, but this is the general consent that I go over with the patient. So first of all, the risks, there are really not that many. The major risks really are that you need to discuss with the patient that there is a chance that they may need to be rebiopsied, that for different reasons such as insufficient samples or technical issues that they may have to undergo another type of biopsy. Also, hematoma is not uncommon, but not a terribly bad risk. Worse risks, but extremely rare, are uncontrolled bleeding. I've actually never seen this, but I know that in some instances, after a biopsy, a surgical stitch may need to be placed because bleeding will not stop. But again, this is very rare. Infection can occur and should be discussed with the patient, although this is also very rare, as well as allergy to lidocaine. I discuss with the patient potential issues, which are that there will be a small amount of pain and discomfort. Usually it's very manageable and the patients do well, but there's a small amount of pain. In some instances, a clip is placed, and in which case you need to discuss this with the patient in advance. This is an example of a clip which I would show the patient if I'm going to put it in. It's very small. This is embedded in collagen. Other issues are if the patient is on any blood thinners, such as Coumadin or aspirin or vitamin E. We prefer not to do core biopsies if the patient is on Coumadin. FNA biopsies are not such an issue, but there can be extensive bleeding with the core biopsy if the patient is on Coumadin, and so it's preferable if the patient is taken off, if they can be, or another type of biopsy is performed. Although there is a study out that shows that this is possible to do. Many patients are on baby aspirin, which I don't consider a problem, But if they're on regular aspirin, high doses, or vitamin E, they do have an increased risk of bleeding, especially with core biopsies. As with any biopsy, you should go over the benefits, which would be early diagnosis of cancer or exclusion of cancer, and alternatives, which would be other types of biopsies, including surgical biopsy, or of course the patient doesn't have to have the biopsy, it's up to them. So starting with the ultrasound-guided biopsy techniques, again, there's many different types, and so the basic ones are the core biopsy, which I have illustrated here, fine needle aspiration, and then ultrasound needle localization for surgical excision. And to briefly go into why we do a biopsy, the different indications, and this is true for ultrasound-guided core biopsy, but really for all breast lesions. The majority of the lesions that we will biopsy are BI-RADS4 lesions, which Dr. Frenna discussed for ultrasound, for A, B, and C. And usually with ultrasound, these are masses, such as these illustrated here. Other reasons for doing, or other types of lesions are BI-RADS5 lesions, or lesions that are highly suggestive of malignancy. Now, these lesions most likely will come out surgically anyway, so why would we need to do a needle biopsy on them beforehand? The reason is that with needle biopsy, you can do better surgical planning, meaning if you can get a tissue diagnosis with a needle biopsy, the patient can then have a one-step surgery with lumpectomy and node dissection or sentinel node, instead of having two surgeries, an excisional surgical biopsy and then the final surgery. This is also very helpful for pre-surgical neoadjuvant chemotherapy for locally advanced breast cancer. Biopsy can provide receptors and for the patient to have neoadjuvant chemotherapy. Also, needle biopsies prior to surgery can help with decision making. A full workup can be done so the patient can be given the option whether they may need mastectomy or are eligible for lumpectomy. And lastly, some BI-RADS3 lesions are biopsied. BI-RADS3 lesions are probably benign, and usually only a 6-month follow-up is recommended. However, if the patient desires or cannot follow up in 6 months due to different issues such as pregnancy planning or anxiety, then these lesions can also be biopsied. Also, sometimes high-risk patients, there's an overall increased risk, so we may biopsy BI-RADS3 lesions in high-risk patients. Okay, so the basic setup for ultrasound core biopsy, I have here, we use sterile technique, which for core biopsies I use betadine and then also alcohol. Anesthetic using 1% lidocaine, 11-gauge needle, 10% formalin to put the sample in, and then our basic biopsy gun. Again, there are many different types. We use a disposable 14-gauge needle and then a reusable barred biopsy gun, although there are very many, like I say, a few variations. And the basic concept of this gun is that it is spring-loaded and has two components. It has a 5 to 6 millimeter needle tip, and then right behind it is a tissue trough or an acquisition chamber that's about 2 centimeters, and then an outer cutting cannula. So when this biopsy gun fires, the inner sampling needle moves forward, followed almost instantly by the outer cutting cannula, which cuts the tissue and secures it within, secures the sample within this acquisition chamber. The needle is then pulled out after each use, and the core of tissue is deposited in the formalin. And usually we do 4 or 5 passes. Other types of similar biopsy devices are one that looks similar to this, which is completely disposable. And the other major device would be using a directional vacuum-assisted biopsy probe instead, which is here. So the device is a little bit larger. Usually it's acquires larger samples. This is an 11-gauge. And then also it's connected with tubing to this device here, which provides suction. So the basic concept is the same. This fires, and again, there's an acquisition chamber and an outer cutting cannula, but the needle can be left in the breast, and the core gets sucked back by vacuum and can be retrieved here. And this needle can turn 360 degrees and keep acquiring samples at a few degrees. So usually you can get as many samples as you need fairly quickly. We usually, with using this device, usually about 12 samples are obtained. So the advantages of this are a larger sample size and faster retrieval. However, with ultrasound, we have not really found that this type of device is beneficial because it is fairly cumbersome, as you can see, for handheld use compared to this type of device. It's time-consuming to set up. This large needle can be disturbing for the patient to see, as they can watch the biopsy as they are supine. Also, we get good results with the handheld device and haven't found it necessary to use this type of device. However, when biopsying calcifications and using the stereotactic biopsy table, we do use this type of device. With stereotactic biopsy, the patient isn't seeing this. It is not handheld. It is held within the device. And because usually we are biopsying calcifications, it's advantageous to get larger tissue samples. So that's what we use this type of device for. So the technique we use for ultrasound-guided core biopsy, as you see here, we have our ultrasound device and examination table that the patient is lying supine on. Using ultrasound, we identify the lesion, as we have here, and the most convenient approach. And it's important to choose an approach that allows biopsy of the lesion to be parallel to the chest wall and transducer to eliminate pneumothorax. As you see here, this is the lesion, this is the pectoralis, and then this is the lung. So you want a parallel approach, and obviously not an approach going this way, as you could cause a pneumothorax. The patient is then prepared with sterile technique, and local anesthetic is given with a skin wheel and then 1% lidocaine, which is given at the biopsy site and along the path, the trajectory of the needle. A skin nick is then made with an 11-gauge surgical blade. So here is an example. We have our lesion. This is the core needle in the pre-fire position. Again, you want to allow for a parallel throw of the needle for about 2 centimeters. You warn the patient of a click and then fire the gun. Here's the post-fire picture. I also like to get orthogonal images to demonstrate that the needle is within the lesion and not to the side of it. Here it is actually a little bit above the lesion. Then the gun is removed and the tissue sample, as we see here, is teased off the acquisition chamber and into the formalin. We have one sample here, and again we repeat this 4 to 5 times. So another quick example, a lesion, pre-fire image, post-fire image, and then an orthogonal image with the needle within the central aspect of the nodule. The other issue is whether to mark the biopsy site with a biopsy clip. Indications for this would be to mark a malignant lesion prior to neoadjuvant chemotherapy, as lesions may not be apparent after chemotherapy. The area usually is still surgically excised, and so a clip is helpful to mark the area. Also, small masses may possibly be obscured or mostly removed after biopsy. So in case of subsequent need for localization for surgical excision, it is helpful to have a clip in place. There are many different types of clips. Some are made of titanium or stainless steel, and often with or without collagen or vicryl pellets. And the collagen or vicryl pellets aid in the placement and expand within the biopsy cavity to keep the biopsy clip in place. The insertion is similar to other percutaneous biopsy procedures. Here I have one type of application device. This is an 18-gauge needle, which has the biopsy clip within it. Once the tip of this needle is within the lesion, then this can be pressed in to deploy the biopsy clip. And a post-procedure mammogram is always done to document correct position of the biopsy clip and to assess for migration. This is a real-time image of the clip being put in. You can ignore this wire. This was for an ultrasound needle localization, but a clip was placed after that, which shows that this is the application device. Once the tip is within the lesion, then the plunger is depressed, thereby pushing in the clip. The clip is not this big. This is also the collagen. And this is put through the skin nick that was made for the biopsy, and this should already be numbed with lidocaine. Oh, I didn't mean to do that again, sorry. So again, we're parallel to the chest wall. You want to make sure you don't want to go into the lung. Okay. Very important then is follow-up after biopsy. At our institution, it takes about 5 days for the results after a core biopsy. So after these results are in, it is important for the radiologist to go back and look at the original imaging findings to make sure that it corresponds with pathology. Also, it's important to have a system in place to make sure that all pathology results are followed and that the referring physician is notified. You need to make sure that none of the pathology falls through the cracks. And then in general, this could be a whole lecture unto itself, but what you do with different types of pathologic results. With DCIS or invasive cancer, the patient is referred to a physician. Usually we alert the referring physician, who then recommends a surgeon for the patient. Benign results, which are radiologically and pathologically congruent. A follow-up is decided either annual or 6 months, depending on the original imaging findings and the pathology and what the radiologist is comfortable with. Non-congruent or insufficient pathology results. In this case, a re-biopsy is needed either percutaneously or surgically. And then the other issue is non-malignant lesions with risk of upstaging or pre-malignancy. This can be a whole other lecture into ourselves. Dr. Mercado talked about papillary lesions. Many of these lesions, excision is recommended, but many of these lesions are also controversial. Okay, so next I'm going to talk about ultrasound fine needle aspiration biopsy. We just talked about core biopsy. This is a 14-gauge core biopsy needle. And then this is what we're talking about now, which is a 25-gauge needle. With this 25-gauge needle, we aspirate the cellular material from the breast lesions for cytologic evaluation. And the technique is similar to core biopsy. However, there's no throw of the needle. Also, no skin nick is needed. The advantages of this type of biopsy are that it is often quicker than core biopsy. It is less invasive with decreased morbidity. In general, less painful with less bleeding, decreased recovery time. Just in general, this is almost like a blood draw. Patients do not experience much pain with this type of procedure. Also, for certain lesions, they can definitely be advantageous. For lesions that are very close to the chest wall and close to the pectoralis, there's less risk of causing a pneumothorax because there's not the throw that you have with a core biopsy. Also, small lesions can be obscured by core biopsy after the first pass, or with this technique, that should not be an issue. Also, oftentimes we biopsy probable cysts or cysts with debris. With this type of technique, aspiration can be performed in real time, and the fluid can be suctioned out and confirm that this is a benign cyst, where with a core biopsy, the cyst would be obscured and the fluid would dissipate in the breast, so it's harder to make that type of diagnosis. The major disadvantages of this type of biopsy are that it is a much smaller sample size, so it really is all dependent on the cytopathologists that you're working with at your institution, whether they're available, whether they have experience in this type of biopsy, and what their preference is. Basically, we have a cytopathologist on site that makes sure that we have adequate results at the time of biopsy. If you don't have a cytopathologist on site, the patient may have to come back too frequently for a repeat biopsy due to inadequate sampling. Also, the cytopathologist needs to be trained and comfortable with diagnoses from FNA biopsies. So, if we actually do FNAs and have cytopathologists that are comfortable, and it's an excellent technique if you're able to do it. The other advantage is that you get a diagnosis at the time of biopsy, so you can tell the patient at that time what their diagnosis is, and also you can assess for concordance at the time of biopsy, which I think aids in correlation of biopsy results. So this is the basic technique. Again, we have the ultrasound machine, table for the patients. I treat this similar to a blood draw and only use alcohol for sterile technique. Again, this type of biopsy does not cause much pain. Some people don't use any kind of anesthetic. Others use topical anesthetic with ethyl chloride, or I use lidocaine just because you do make a couple passes, and with lidocaine the patient only feels one stick. However, it is not really necessary. Then we use a 25 gauge needle, and this can be performed either by itself or with aspiration with a syringe, and this depends on the preference of the radiologist and the pathologist. Basic technique is again the same as ultrasound core biopsy. The needle is placed within the lesion, and then once it is in the lesion, it's thrust back and forth to collect cells within all aspects of the lesion. It is then removed and given to the pathologist, who uses another syringe to expel the cells onto a slide. The material is then fixed, and then the slides are evaluated by microscopy. And they do this at the time of biopsy, where they can assess for adequacy of the sample to see if additional passes need to be done. Usually 3 passes are done, but as many passes can be done as are needed to make a diagnosis up to a certain point. And then usually preliminary pathology results can be given, as I discussed earlier. So for FNA, again, the follow-up is exactly the same as core biopsy. You need to follow up on the final pathology results, which are usually not changed. Again, correlation is essential, and notifying the referring physician, and then this is also the same as before. The last type of ultrasound-guided procedure I'm going over is ultrasound-guided preoperative needle localization. So for any of these lesions that we biopsied with needle biopsy, if their pathology comes back malignant, discordant, atypical, or pre-malignant, these need to come out surgically. And as they are not palpable, they need to be localized for the surgeon. And again, if they are seen by ultrasound, it's a very convenient way to localize the lesion, although localization can be done by other methods in addition. Also, localization of lesions for surgical excision can be done for lesions for initial histologic diagnosis, as per the preference of the patient or the surgeon. In the past, for histologic diagnosis of a breast lesion, the only option was surgical biopsy. But over the last 15 years, needle biopsy has largely replaced surgical biopsy. This is from the ACR. Needle biopsies have been shown to have a lower cost, lower morbidity, shorter procedure time. They're least invasive and have similar to equal accuracy as surgical biopsy. So really, like I said, needle biopsy has largely replaced surgical biopsy, although certainly if the patient or surgeon wants a surgical biopsy, that is an option also. The risks are the same as other types of biopsies. However, there's an additional risk of dislodging the wire. Oftentimes, once the wire is placed, the patient goes from the radiology suite to the surgery suite, and there could be, you need to be careful that the wire is not dislodged. There are a couple different types of wires. The main ones are the Cofans and the Homer wires. The Cofans, as shown here, is a straight wire with a hook at the end. It is inserted via a 21 gauge needle. This needle is inserted into the breast similar to the techniques we went over earlier. Once it is in accurate position, then this wire is within this one. The 21 gauge needle is removed. This needle stays in place and is deployed, and thus is secured within the breast. The other type is a Homer or Jwire. This is a flexible J-shaped wire. It is inserted via this needle. Once in place, this retractable needle can be moved forward, securing it in place. And this whole device stays in the breast for surgery. The advantage to this is that if it's in the wrong position, this is retractable. So this can come back. The needle can be taken out and repositioned. So again, same technique. Here we have a lesion. The needle is inserted into, and in this case, through the nodule, approximately 1 centimeter. Once it is in place, then either the J-wire is advanced or the hook wire is deployed. Also, with this technique, I like to get orthogonal images to make sure that the needle is in the central portion of the nodule. A post-procedure mammogram is done, and then the wire is further secured to the skin. This is a post-procedure mammogram, so we have the wire coming through. This is the needle that we wanted, or I'm sorry, the mass that we wanted localized. This is just a benign fibroadenoma. Depending what the surgeons like, annotations can be made on the mammogram to further help them localize the lesion. Again, the wire is further secured to the skin, and then the patient is sent to the OR with these films. Then, very important is the follow-up specimen x-ray after the lesion is removed. Sonographically localized images may also be mammographically visible, as is this nodule. However, some lesions are not visible on mammography, and a biopsy clip can be placed that will mark the area for specimen radiography. If the nodule is not mammographically visible and a clip is not placed, you can also do a specimen ultrasound, or an ultrasound of the specimen, to make sure that the lesion was removed in the specimen. We also check for wire integrity to make sure the tip of the wire is still in place and this wasn't accidentally lacerated and left in the breast. And it's also important to assess for additional lesions, such as unsuspected calcifications within the specimen. And some surgeons like you to check for adequacy of the surgical margin. This is actually pretty close to the surgical margin. And okay, I have 1 minute left. I'm going to stop here. As I said, I still haven't gone over mammography techniques or MR techniques, but I did go over most of the main points under ultrasound, and the rest of the lecture is on the CD.